Good evening, everybody, and a warm welcome to all of you. And thank you, Dr. Torvid, for giving your precious time to us. Before starting the academic proceedings, I would like to introduce the members of the GDM Committee of the Stillbirth Society of India. We have Professor Bharti as the chair of the committee and Dr. Dalia Rafat as the secretary. We have members from all over India, and the committee, everybody wants to join this particular committee because of the importance of the committee. Dr. Anuratha Singh from UP, Dr. Charmila Avayu from Tamil Nadu, Dr. Divya Agarwal from UP, Dr. Hamid Ashraf from UP, Dr. Manju Prabhakar from UP, Dr. Priyankur Roy, West Bengal, Dr. Paridhi Garg, Dr. Subhash Malia from Kerala, Dr. Vaishali from Maharashtra, Dr. Veronica from Delhi, and Dr. Yashi Pandey again from UP. So it's a pleasure to be here together again for this monthly webinar. And I now request, before we begin the proceedings, I would like to introduce the chairperson of today's proceedings, Dr. Anuj Maheshwari. He is MD, FICP. I'm not even attempting to read all his degrees. He's the Vice President of RSDI, Governor, American College of Physicians, India chapter, and currently he's a professor and head in medicine, BBD University, Lucknow. Now I request Dr. Nuzhat to introduce our esteemed international speaker and welcome the delegates.
Thank you. Thank you, Dr. Tamkin. Dr. Tamkin is the founder secretary of the Stillbirth Society, and we are in our infancy, still, I suppose, learning to crawl out. So she asked me whether I would do the introduction in place of Dr. Neelam, and so pitching in for Dr. Neelam. And just a little bit of introduction, we are known as the diabetes capital of the world. Can I have the next slide, Dr. Tamkin? You have the power. So right from the time when it was first diagnosed that it can cause a stillbirth to post-insulin era, we have come a long way as far as perinatal mortality is considered. But we still, can I have the next slide? But we still lose about, a lot of stillbirths in India because detection is a problem, identification and screening is a problem. India is a vast country with high resource set as well as poor resource setting. It is believed that women with diabetes disorders wants to have a stillbirth when compared to non-diabetic population. So with this background, we would like to invite each one of you to have joined over here. I would like these sessions to be very interactive from where various parts of India joining in, and we hope that we will also get together to have some data together over a period of time. This is the third seminar only for the Stillbirth Society, but we look forward to each session on every aspect of stillbirths that can be possible. So introducing Dr. Torvid or Professor Torvid Kiserud from Norway. I had the privilege of meeting him. Can I have the next slide, please? In the Fetal Growth Conference, and I was very impressed by the fact that he was the giant of a researcher, and still he was working in the poorest of the resources, a country like Ethiopia. And I thought, a beautiful combination where research of the highest level being applied to the people who really have nothing, and he is a most appropriate person to come to India and help us. How do you do the screening in resource poor countries? So I asked him whether he would like to take the session on why big babies die in diabetes. And to introduce him, I couldn't count the number of papers that he had, the way Dr. Tamkin said for others, but just to tell you, he's a professor of OBGYN, University of Bergen. He not only did his obstetrics and fetal medicine specialist, but he's also has a degree in tropical medicine, and that makes him a great resource for us in India. A researcher, has innumerable publications. Everyone knows him for his Doppler work for the International WHO Fetal Growth Study. And he was responsible for setting up the fetal medicine unit at the University of Bergen. But I would also like to mention that he works as a director at the Minch Hospital, Ethiopia. Professor Torvid, these are the things that I have compiled from my information or what I had done as a search on you. I may not be absolutely appropriate, but I was very fascinated that because of his work on gynec fistulas, he could open up a center not only in Ethiopia, but also in Norway, and is the director of this center. So a combination of a brilliant clinician, surgeon, fetal medicine specialist, a sports person, absolutely fit person to meet and be with. So my proud privilege to introduce Professor Torvid to an Indian audience, and I hope that we will be able to invite him to India one day and host him in India. We are known for our hospitality. So over the next few minutes, Torvid, the floor is all yours. Thank you. Dr. Tamkin, if you stop sharing, then he will be able to. Thank you. Dr. Torvid?
Yes, I am talking, but I would like to show my slides. Could I share screen? Or? Thank you for your introduction anyway. I am rather humbled. Why do big babies die? It's a shorthand for asking in diabetes mellitus. And we think that that is a combination, that big babies also have a more frequent death. That is true. But even the not so big baby has also an increased risk of stillbirth in diabetes mellitus in pregnancies. I would like to take you briefly into some physiological issues before we go to the physiology of the fetus that is under the under the pressure of maternal diabetes. So if we go to, I see I have to use my pad only, okay. If we go to the fetal circulation, we have this classical central division between the low oxygenated blood that is collected into the right side and then is directed bypassing the lungs into the descending aorta and going to the placenta. Now we are going to discuss more the via sinistra, which is the oxygenated part, which comes from the placenta in a vein through the cords into the abdomen of the baby and is distributed either to the liver or through the ductus venosus, where it is shunted predominantly into the left side through the foramen ovale, left ventricle, and then ejected through the aorta to feed coronary circulation and the brain circulation as main issues. This is a well-known physiology to do you, I suppose, and we have looked at the circulation that goes, how much blood actually goes through the ductus venosus in humans. And it is not as it is in experimental animal studies. I have problems actually to advancing this here for some reason. So if we look at how large proportion of the umbilical venous blood that actually goes through the ductus venosus in the humans in comparison to experimental situations in animals, it's not 50, but 30% at mid-gestation, and then it is reduced to something like 20% towards the end of pregnancy. If you then look at, I think this is, Are you going with the slides or no? So this is what we also know from growth-restricted fetuses, that when we are in the condition that, that we have problems with the placenta due to placental insufficiency, then there is an increased shunting through the ductus venosus, which is the blue is with increased pulsatility index in the umbilical artery, or when it's even absent or reverse blood flow in the umbilical artery, a sign of gross placental insufficiency. There is also a gross shunting of blood through the ductus venosus. So it is very important part of the fetal physiology to really maintain oxygenated blood to the heart and brain. Now, if we go back to this one, we can notice that if it is only 30 to 20% of the blood that is shunted through the ductus venosus, it means actually that 70 to 80% is taken up by the liver. So the liver is actually a high prioritized organ in the fetus, taking the majority of the umbilical blood, 70 to 80%. See if we can go on now from this. Chirikov in Hamburg obliterated the ductus venosus in sheep to see what happens, because now when obliterating the ductus venosus, all blood went through the liver, which is 100%. And then he looked at what happened. Well, the body weight in the fetus was, and the control was much the same, but the liver grew compared to the control fetus, which was the twin. And when he looked at the liver proliferation, means cell proliferation, then there was a huge increase in proliferation when flow increased, which means this is a very important issue. It is not the placenta that decides how big the baby is going to be, but it is the liver who is going to do it. And it does it by increasing the IGF, the insulin-like growth factor 1 or insulin growth factor 2. And when you look at how the heart is in those who have occluded ductus venosus, the heart has increased, the skeletal muscle is increased, kidney is increased, the placenta remains the same, which means that the liver is a main brain for developing the fetus and how it is going to grow. And so we have these fetuses who have diabetes. How are they doing? And that's what we see here. The ductus venosus shunts the same as in the reference group until it comes into this third trimester when it is blunted. It's not increasing. And why is that? We have this situation that blood comes into the umbilical vein. It should go through the ductus venosus or into the liver. And now we have noticed that in the fetuses where the mother has a pre-gestational diabetes, there is a reduced flow in the ductus venosus at the end of pregnancy. We also noticed that the ductus venosus had distended and still the flow was low. So there was a distended as if it was trying to compensate, but the diameter was big, but the total flow was low. The velocity in the ductus venosus is dependent on how big pressure there is in the umbilical vein compared to central one in the inferior vena cava. But the velocity was low, which means that the pressure gradient across the ductus venosus is reduced. Why is it reduced? Because there is a reduced resistance in the liver, because this is programmed by the continuous shedding or the continuous conditioning of high glucose in the blood. So to summarize a little, the blood in the normal ones in the liver is huge. The blood that comes from the umbilical vein is huge. This is the arterial blood or the oxygenated blood in the umbilical vein that comes into the liver. And this blue one is what comes to the liver from the portal vein, which is not oxygenated or low oxygenated. This is the normal condition. In the diabetic pregnancy, no, sorry, in the macrosomic, which has a not diabetes, which we also have examined before we started on the diabetes, we see that for those who want to become macrosomic, they needed a huge flow into the liver. So the macrosomic growth is supported by flow in the liver. This shows the flow to the liver from the umbilical vein in the macrosomic compared to the reference. It grows, and it is in correspondence with the growth of the baby. In the diabetic one, which is the red one, we should think that once it goes towards macrosomic, it should follow the macrosomic normal one, but it doesn't. It blunts off and is comparable to the normally growing fetuses. So it means that although they have diabetes, although they make macrosomic fetuses, the flow, the umbilical flow has not increased correspondingly. So this is the diabetic one with the pre-gestational diabetes in the mother. You see in mid-gestation, they have set out to make a huge flow into the liver, corresponding more than the normal ones, even more than the macrosomic ones without diabetes. But once they come into the second or to the third trimester, then you see that they doesn't achieve the flow to the liver compared to the normal ones. So the macrosomic growth is not supported by umbilical flow. And this is a mismatch. What is a consequence of this? Well, if you look at the degree of glycemic control, let me just move here to see my own slides. So then you see that this is, sorry for moving around like this. Then you see that this HbA1c, the higher it is, the less velocity in the ductus venosus, less fraction is shunted, and the velocity and the flow volume is also reduced. So it means that if you can keep a low HbA1c, then you are doing better. But even if you have a normal HbA1c, sorry for this, you see that the velocity is reduced by 1 standard deviation compared to normals. So it means that even at well-regulated diabetes, you have an effect where the pressure in the umbilical vein is low and flow is low. The reason for this is that in the liver, it sucks blood from the umbilical vein. And it builds itself to a low resistance, so flow goes here, even when the pressure is low, still blood is preferentially going to the liver. But the umbilical vein is not producing as much blood as it should compared to the growth that it was promised in the mid-gestation. But all this blood is essentially going into the liver, which is stealing away from the ductus venosus. There is a competition between the ductus venosus and the liver. And in the third trimester, it means that there is too little going in the ductus venosus because the liver has got the setting or taking it all or a lot of it. So when we come to this here again, in the third trimester, ductus venosus flow is low. We saw that the pressure is low. We saw that it is distended ductus venosus, but it doesn't help. It is still low. It is not a good position to be in when you're going into difficult times near term, where the demands is increasing, or even when you get into hypoxic periods when the contraction comes. I think this is a very interesting slide. It shows you the lactate after birth in the umbilical artery in those pregnancies. And on the baseline here, let me just have the pointer here. On the base, along the baseline, you see that there is the increasing shunt fraction through the ductus venosus, or the other way around. The less ductus venosus is sent, the less blood the ductus venosus receives, the higher is the lactate in the arterial side on the baby. So when it is as it lowest, it means that the lactate is highest, and it's exactly the expression of the same. In these fetuses, essentially, well, let me bring it to the end and for a conclusion. The trajectory for growth is set high in the fetus. Also, I mean, in the pregnancy where there is a gestational age, a gestational diabetes. And the fetal liver has read this at mid-gestation and is set out to make a big baby, but is not supported by the blood that comes from the placenta in the third trimester, probably because the placenta is also affected by the diabetes. The placenta, no, I mean the liver, however, has got a low resistance, which favor liver perfusion to ductus venosus, and the baby has therefore reduced capacity to compensate whenever there is a hypoxic situation. The distension of the ductus venosus does not compensate for this skewness, and the capacity has been reduced, which is a danger for this baby. I thought this was how far I wanted to bring you. If I can still move this, I cannot probably.
Could you click on the arrow, directly on the arrow, lower down on the slide, left-hand side of the slide?
Which one?
The same slide, if you go, yeah, this arrow.
Okay,
when
I
you
have
move.
heard this up. Yes, okay, sorry for that. It is not up with me unless I come down here. So I want to thank my collaborators, those of them who have particularly been involved in this study. I have some extra slides I can share with you if you come up with some questions. Thank you so much. I'm sorry for the disturbing progress of the slides.
So,
yes, I cannot hear you.
Okay, so there's thank you so much, Dr. Torvid, for giving your time. And we were going through the citation that accompanied the Iron Donal, award that you got. And Dr. Nuzhat has been talking so much about you, and we can understand how busy you are. In spite of that, you have given us time. So thank you so much for being here with us today. There's one question in the chat box. There's a clinical scenario by Dr. Nuzhat. 36 weeks, large for gestational age, 100th centile poorly controlled diabetes. What is your protocol for fetal surveillance, and when do you plan delivery?
We have a fixed protocol with this that we are, and that is not governed by our findings at the moment. These are new findings, so we haven't changed what we have been doing in recent years, but we have understood more where we have to go in the future. And that is what this talk has shown. For my personal, if I had been in the situation that I had this kind of fetus, I would have not relied on my Dopplers, which are usually made a battery of examinations to assess growth-restricted fetuses, and have been very successful for the early growth restriction. This is a metabolic condition, and which particularly is expressed in the liver function and liver circulation. So this would be the right place to go. They are quite intensely followed in my department by every second or every third week towards the end of pregnancy. And when they have a large baby, as you mentioned here, they could easily go into fetal death, and we are not good at predicting that. We have to do prospective studies for this. So it's dangerous to take findings from this study without first having done prospective randomized trials to how we can do it. But I can show you, if I can take the pictures forward here. I have to go down again, as you say. And this is where you have what you commonly see. This is the baby, this is the umbilical flow. The ductus venosus is just going off here, and the flow in the umbilical vein is then continuing into the right side to meet with this one, which is the portal vein here. You see my pointing?
Mm-hmm.
So this is the main portal stem. Here's the umbilical vein coming up, and this is still the left part of the blood flow into the right side. And you can then measure the blood flow here, because we had in this figure, when you see the black line here, this is the flow in the left portal vein, which is reflecting the increased flow to the liver. And this is an easy vein to measure and could be used in the future for assessing and predicting risk for these babies. So going into this position here, doing the Doppler from this angle down here, and then measure the flow velocity simply. And if this is increased compared to the normal ranges, which we also have made, it will be one way of monitoring these fetuses. In general, if there is a macrosomic, we would like still, if it is possible, to do a vaginal delivery, but they tend in general to be delivered earlier after we have monitored them with the CTG, short time variation, computerized short time variation, and repeated Dopplers to see that they haven't gone into any disasters or imminent disasters expressed in the ductus venosus. The middle cerebral artery, the umbilical artery are usually not very useful in these situations. It's rather to go for the liver. But still, we are more precautious than we can be by the monitoring, because monitoring is, with these Dopplers, not well established yet.
Okay, the next question was, do you recommend ductus venosus Doppler as a surveillance tool in diabetic pregnancy? That was again Dr. Nuzhat.
Yes, I do so, because if you have pregnancies where you have also vascular complications in the mother, they have a higher risk also even of growth-restricted babies, which is also a problem in diabetic pregnancies. And they are not always easily detected. But doctors venosus will then maybe be more a good indicator, but comes very shortly, changes very shortly before the baby is in serious problem. So it's a late sign. And particularly after the 32 weeks, it is when the physiology is more mature in the baby. All what we know about surveying growth restricted before 32 weeks doesn't really apply in the same way because of the maturity that makes the baby more competent for redistribution without showing it off in the Doppler signs. So it's still difficult. We are not good at doing the doctor's venosus and predicting imminent problems in the babies at this stage, at least not statistically seen.
Okay. There's another question from Dr. Dalia. Is fetal growth velocity a better predictor for assessing FGR in GDM babies?
So let me just repeat, is the growth velocity, is that what you asked for?
Yeah, that's what. Fetal growth velocity a better predictor for assessing FGR in GDM babies?
The best, I think, is just to look at the biometry, yes, because the trajectory is there. It's just the physiology behind which is different in the diabetic, which is the danger. And the more it is a mismatch, the more is the risk, I suppose, because that's what you see in the lactate results with us. And also that's what we know from statistics otherwise.
Okay, thank you. Dr. Uma wants to know, we don't normally look at DV in normally grown or large babies. Should we be doing this, and what is the interpretation we should follow?
Do you mean the DV in normally in
Yeah.
large? I use the doctor's venosus not only for looking at the pulsatility index, which most people use. The pulsatility index says something about the stress on the heart. And when there is an increased end diastolic pressure due to diastolic dysfunction, that's what you see in the pulsatility of the ductus venosus. I'm looking at the absolute velocity, means is this high or low? And that is a much more subtle thing, and then you have to be more accurate when you are measuring it. But that tells you something about the pressure in the umbilical vein, whether it is normal or not. It is not something that we are going to be good at all over the place, because it is very demanding and it is varying all the time. I think that at the time when the very clever or very good IT people in India has developed the artificial intelligence, that we can do that kind of summarizing everything that we find, including this kind of findings, I think we will be much better at predicting it. So I will rely on more what we in future develop of collecting all data from mother and the baby, including what we have shown you today, to be a better predictor using AI, I mean. And I think India should be the place where you could develop it with all the IT knowledge you have.
Dr. Nusrat, would you like to say something, add something to that?
No, we do have the resources, Torvid, I suppose so. Mediscan, Dr. Suresh, we have met Dr. Suresh, and I suppose artificial intelligence can be put up, and we can definitely work together, I suppose. Dr. Torvid, before I other questions you want. Would it be possible for us, we are all clinicians here, to have your fetal surveillance protocol for diabetic babies, because that would be the most important part of the of what we take home from here. What would be your fetal surveillance protocol? When do you start fetal surveillance? Do you use CTG? Do you use NSG?
Yes, we do. The diabetic patients with us, they start surveying since they are pre-gestational, as we have been talking on today. They start at a very early stage, and they are diligently followed on with CTG growth measurements, and including the conditional growth measurements, which is telling you something about the growth velocity, or rather the growth, the conditional growth. And that is then we intensified if you have when you come into the third trimester. Depends on the maternal conditions. You will have people who have, in my country, very well glycemic control. But to have a good glycemic control doesn't mean that they are evading problems. And the reason for that is that many of these patients, they have had diabetes for many years, and they want to live as much the same way as all other people lives. So one day they go to a place and have a feast together with people, and then they take whatever they want to eat, and they just have a little extra insulin to compensate for that. So that the insulin control is not the only problem that we have for these patients. It's also something about attitudes. And I'm afraid that glycemic control alone is not going to solve all our problems. We have to consider that we will not let these pregnancies go beyond 14 weeks. We will usually either induce them or do cesarean section, depending on their previous history, and that will usually be between 38 or 39 weeks.
So, Dr. Nusrat, there are a few more questions, but I think you already asked for the protocol, and I hopefully
I can't give you the protocol here, but I can send you the protocol if that is
yeah. So we'll be communicating later. I would now request the chairperson, Dr. Anuj, to please say the concluding remarks in a few words.
Thank you, Dr. Nusrat, and thank you, Dr. Torvid, for a very interesting talk. What I could listen, being a clinician, being a physician, it's very different for me. Many of the facts I could know for the first time, and but it is also very much important that we should share the forums most of the time, so that we can know what is the more concern for us and what is the more concern for our other colleagues of the other specialties. When you say that, why do large baby die? Of course, if they don't die, the problem may be solved at this point of the time, but it is not really going to be solved as a physician for me, because my problem lies in the large baby. When the large baby is there, he will become diabetic whenever he will be grown up. And the mother who is delivering that large baby, she is on the higher risk of getting diabetes. So our concern remains absolutely on the larger way of simply being, why do large babies die? Of course, they should not die. But even if they do not die, I think as a physician, they should not even born. We want neither low birth weight baby nor large baby. We want the normal weight baby. So that is my concern in all the way. But your talk was very fantastic and I really enjoyed. I could know that it is not only the size which makes the difference. Of course, when the baby is large, the hypoxia and other risks are also there, which may cause a threat on the life of that baby. That's all.
Thank you.
Thank you so much, Dr. Torvid and Dr. Anuj. Now we move on to the next thing on the agenda. That is, I'll now invite Dr. Bharti. Professor Bharti Maheshwari is professor and head Muzaffarnagar Medical College, Muzaffarnagar. She is MS Diploma in IVF and Reproductive Surgery, MCI FIME Fellowship in Medical Education. She is a very active member of the FOXI board at the level of Uttar Pradesh, at a level of a city, and also at the national level. Chairperson FOXI MTP Committee, Governing Council member, COG, Joint Secretary, UPCOG, Vice President, Merit, OBS and Gynae Society, and done a lot of work on contraception. She's author and editor of many books, many invited lectures and orations, and has a great organizational experience of organizing many successful conferences and workshops. And apart from that, she's a selfie expert. So you already saw her work. Right now it is there in the city. Dr. Dalia Rafat is the secretary of, and I'm really proud to introduce her. She's my own student. Her area of interest is fetal medicine. She's working as an assistant professor at JN Medical College. Fetal medicine, genetics, high-risk pregnancy, medical disorders in pregnancy, especially diabetes. And she did a lot of work, even right from her residency. 3 projects, 1 patent, 1 book, 2 chapters in books, 20 publications, various papers and poster presentations, and member of various national and international professional bodies. So we have these 2 people leading the GDM committee. And now I request Dr. Bharti to please start with her talk.
Thank you, Dr. Tamkin, and thank you. It's really memorable evening and memorable part to join this committee, GDM committee, and giving me opportunity to work in this committee. And really, today is a very important lecture by Dr. Torvid and Dr. Nazar. You have arranged for this international speaker, and it's really, we got a very informative talk and very good sensitizing thought for fetal surveillance in the gestational diabetes. And beside that, Dr. Anuj Maheshwari, we all know at the national international level. I'm very proud to feel that he is my real brother. Many of you know. And in this webinar, I am really feeling proud that he is chairing the session. So as in the very shortly, I'm just introducing my committee. Gestational diabetes, mellitus, and other endocrinological disorder committee of Stillbirth Society of India. And I'm chairing this committee, and secretary is really very proud and very hardworking and visionary, Dr. Dalia. And beside that, I have around 12 members, and all are from the different places. Dr. Tamkin madam already introduced them, and the purpose is that from the all over country, from Tamil Nadu, West Bengal, Pune, Varanasi, Western UP, Hapur, Muzaffarnagar, Kerala, New Delhi, you can see that we can work together for handling the GDM. And the vision of our committee is that we have to do, and we are planning the multi-centric trials for GDM and stillbirth related issues all over the country. We are doing the plannings to have awareness programs in different states of country for public, for clinicians, and for health workers. And beside that, we are developing the education materials in different language, because we have a different state representatives, and research and other publications, of course, will remain our priority. So, and this is the newsletter. This is a proposed newsletter for GDM committee, and these different topics, they would be covered, and it would be very soon it would be released. So now I comes to in next 10-12 minutes my topic that is given to me, that is hypertrophic cardiomyopathies in babies of diabetic mother. A very good topic. It is suggested by Dr. Nazat, and I'm really feel very, when I have gone through this topic, I thought that most of the time we are not seeing this topic. So it is really sensitization for all of us that how we should see this. So now comes to the main topic that we all know that gestational diabetes mellitus is the most common medical complication seen during pregnancy, and it can be from pre-gestational type 1 or type 2 diabetes, which is being diagnosed before conception, or gestational, which is diagnosed during pregnancy. But we all know that the fetal outcome, it is usually related to the age of onset of diabetes, duration of glucose intolerance during pregnancy, and severity of the mother's diabetes. But despite the recent advances in perinatal care around the world, infant of diabetic mother still remain at risk of multiples of problems in the immediate neonatal period. And many of them that includes like preterm birth, birth asphyxia, macrosemia, respiratory distress syndrome, hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia, hyperviscosity, and hypertrophic asymmetrical septal hypertrophy and hypertrophic cardiomyopathy in infants of diabetic mother. So now I'm next 8 minutes focusing on this. So we all know that infant of, or evidence says that infant of diabetic mothers, they are prone to have hypertrophic cardiomyopathy, and it is well recognized complication and mainly attributed to a compensatory increase in fetal insulin secretion. It primarily affects the interventricular septum but can extend to the myocardium in more severe cases. And the myocardial hypertrophy has been reported in both pre-gestational diabetes and with a wide range of frequencies like 55 to 75% of infants born to diabetic mother. The incidence was lower in cases of pure GDM comparing to pre-gestational diabetes. And the most recent studies shows that good maternal glycemic control does not entirely prevent interventricular septum hypertrophy and minor fetal cardiac functions impairment regardless of the type of diabetes. And it is diabetic cardiomyopathy in the infant. It is usually characterized by significant thickening of interventricular septum, leading to reduction in the size of ventricular chambers, causing transient hypertrophic subaortic stenosis. This transient word is important. There can be associated right ventricular hypertrophy also, and sometimes rarely right ventricular hypertrophy. Aortic outflow obstruction is aggravated by anti-systolic motion of the mitral valve. Usually the infants are asymptomatic, but 5 to 10% they have respiratory distress or sign of poor cardiac output or heart failure. So we clinicians should keep in mind about this problem. The chest radiograph shows cardiomegaly and cardiac hypertrophy, which is best detected by 2D echo. An echo shows hypertrophy of ventricular septum, the right anterior wall and left ventricular posterior wall. And it is transient and it make it unique over the cardiomyopathy, which usually resolve with normalization of plasma insulin level and which usually recover within 2 to 3 weeks of supportive care, and echo finding shows normalization within 6 to 12 months. And supportive care normally includes increased IV fluids and beta blockers like propranolol, but inotropic agents like dopamine and dopamine, they are contraindicated as they are prone to decrease ventricular size and further obstruct cardiac outflow. The mechanism by which insulin causes ventricular hypertrophy have not been delineated, but the heart, it is an important insulin target, and expression of functional insulin receptors by the cardiomyocytes is comparable with that of other insulin sensitive cells. So infants with congenital hyperinsulinism have excessive prenatal and postnatal insulin secretion due to defects in pathway of insulin secretion, and this leads to increase in synthesis and deposition of fat and glycogen in the myocardial cell, and it is usually seen in the mother with poor glycemic controls during the pregnancy. Downstream of insulin receptors, glycogen synthetase kinase 3 beta negatively regulates cardiac hypertrophy. Since expression of this enzyme it is inhibited by insulin, so it is a potential mechanism for hypertrophic cardiomyopathy in the hyperinsulinemic fetus. So the finding of SCM only in patients requiring pancreatectomy suggests that the more severe the hyperinsulinemia, the more likely is the occurrence of a disturbance in cardiomyocytes growth. And under basic conditions, potassium ATP channels are closed in cardiomyocytes and only activated with a lowered ATP-ADP ratio, as occur in the settings of metabolic stress. And by preventing excessive calcium entry and contraction, this channel activation is considered cardioprotective. Routine echo and electrocardiogram ECG of the newborn infant with congenital hyperinsulinism, particularly in the setting of murmur or respiratory difficulties, should be considered. Optimal blood sugar control is a key factor in prevention of all perinatal and neonatal complications. And there are some studies where it is seen that the maternal glycosylated hemoglobin level, it is no indicator of glycemic control. And but in studies of 20 infants of the well-controlled diabetic mothers where there no relationship was observed between eco-evidence of hypertrophic cardiomyopathy and maternal glycosylated hemoglobin. And even 35 patients, they exhibited exaggerated septal thickening, but none had cardiac specific symptoms. So there is, and these studies, they also do not support the third trimester maternal hyperglycemia, other instrumental in the etiology of cardiomyopathy and other complications of IDM. And evidence-based, certain evidence-based fact, which I have found in certain researches, that there is a one where the 11 infants of diabetic mothers with hypertrophic cardiomyopathy have been followed for 30 to 40 months, and they all infants presented with cardiorespiratory distress and were found to have disproportionate septal hypertrophy on echo. And cardiac catheterization was done in 4 infants. 3 had significant subaortic construction. 1 had remarkable improvement after treatment with propranolol. So propranolol has a definite role. And besides that, 2 have received deoxygenated poorly and responded favorably to cessation of therapy. So the natural history of SCM, I have already told you that it is a transient, and with the normalization of insulin level, it resolved in 3 to 4 weeks, and on the echo, the 12 months. And besides that, there is one interesting case where a female infants were born at 38 weeks with a gestational diabetes mellitus and via elective cesarean section, and the glycosylated hemoglobin was controlled 6.7, but the large baby 5.5 kg. The prenatal ultrasound was only significant for a large gestational age fetus without any structural cardiac anomalies. But within the first 2 hours, when the infant developed hypoglycemia, required respiratory support, and then neonatal hyperinsulinemia confirmed, maternal gestational diabetes mellitus as a cause for hypoglycemia, and the infant was effectively intubated for worsening respiratory status. Transthoracic echo shows severe biventricular hypertrophy, especially interventricular septum was thick, and the left ventricular outflow obstruction was there. The left ventricular cavity size was remarkably diminished, and color Doppler show a bidirectional shunting across a large PTA between ductus arteriosus and a moderate size secundum arterial septal defect. Estimated right ventricular pressure was also elevated. And the infant continued worsening, and despite being an adequate ventilatory support, and dopamine and dopamine interval started on the 3rd day of life for worsening hypertension without any significant improvement, and which was also discontinued. Finally, IV propranolol was also started without significant improvement in hemodynamic. But here the milrinone infusion, they have shown the good result and was added 24 hours after the initiation of propranolol, and within a few hours the mean arterial pressure and oxidation indicator started to improve. So the milrinone infusion was slowly weaned off, and the infant was extubated in 10 days. So here this is that the in the cases just after delivery, we must keep in mind that any case, even the diabetes was well controlled, but if the baby has some symptoms related to respiration, we must keep in mind the hypertrophic cardiomyopathy. And beside that, review of 2.5 years prospective study of diabetic women who had carefully maintained diabetic control during pregnancy, it is seen that the mild evidence of generalized hypertrophy when compared with controlled newborn infants, none develop symptom of congested heart failure. So even in controlled just GDM, hypertrophy is there, and these support the contention that careful diabetic management in pregnancy reduces the severity of hypertrophic cardiomyopathy in IDM gestation. So finally, take-home message is that glycemic control in patients with pre-gestational diabetes is recommended to reduce the occurrence of maternal-fetal complications and neonatal adverse effects. And it is therefore recommended to intensify the strategies of sensitization using different figures involved in the care of these patients, like gynecologists, diabetologists, nutritionologists, and all healthcare professionals, and by making patients aware of the fact that planning pregnancy with normal glucose level of glycosylated hemoglobin under 6.5% significantly reduces the risk of experiencing adverse fetal and maternal events. So preconception counseling, preconception care is just very important. Thank you very much, all office bearer of Stillbirth Society of India, for giving me opportunity.
Thank you so much, Dr. Bharti, for that brilliant plan that you have, the vision and mission for your society. I can see Dr. Torvid is still here. Would you like to add something, Dr. Torvid, to this?
Well, not much actually. I think it's very nice to see how you are caring for these patients, and I think we it's still a way to go, as this also shows, that we first understand what actually is going on before we can do anything for them. And so digging into the physiology, as this one has done, is the first place to go before we can organize clinics.
Okay, so thank you, Dr. Torvid, and thank you, Dr. Tamkin. And now I am going to invite our next speaker. She is none other than Dr. Umaram, and she's a director and consultant obs and gynae, Seetapathy Clinic and Hospital, Chennai. She is a chairperson South Zone AIC RCOG, examiner part 3 MRCOG, treasurer ANTR COG, advisory member OGSSI, contributed many chapters and edited books and published on GDM and multiple pregnancies. And her area of interest, GDM, fetal growth, multiple pregnancy, health awareness in women.
Thank you very much, Dr. Bharti, and thank you, Nuzhat and Tamkin, for inviting me to be a part of this program. It's actually quite a pleasure to listen to Professor Torvid. I remember being completely fascinated by how he approached fetal physiology and Doppler at the Fetal Growth Conference a couple of times. So the task set for me by Dr. Bharti is to speak on the prediction and prevention of stillbirth in GDM. I debated about putting a question mark or making a statement, but we'll see where we are at the end of the talk. So I just want to begin by some clinical scenarios, which I'm sure all of us may be familiar with or have actually dealt with. The first is a 20-year-old primigravida with a BMI of 28. Father has diabetes. Booking sugars was normal. She's had a GTT at 25 weeks that was normal. And this is her 20-week ultrasound. At 32 weeks, when she has a growth, she looked a little large. She had a growth scan. The LICA was increased. The abdominal circumference is on the 85th centile. And her fasting sugar, when that was repeated at that time, was 95, and a 1 hour postprandial was 156 in milligrams. Dietary advice was given. She was reviewed in 1 week, but she came back after 2 weeks, and that's where her sugars were. And she wasn't happy to initiate any medication. At 36 weeks, she presented with reduced fetal movements, and there was an absent fetal heart tone. Obviously extremely traumatic to all of us, but I think there are some important messages here which we can come back to in the end, where we possibly could have managed her care a little bit more diligently, knowing that she is particularly at risk for GDM from many factors, including the fact that even at 20 weeks, the baby seems to have started to grow a little bit bigger. The second is a 34-year-old with a BMI of 34, normal booking bloods, low risk first trimester screening, normal target scan, GDM diagnosed at 25 weeks, well controlled on medical nutritional therapy, follow-up scan at 28 weeks was normal. And at 33 weeks, you see that the growth is dropping off. There was growth restriction. IUGR follow-up was initiated. But 3 days later, she presented with a blood pressure of 180 over 110, 2+ protein, and an IUFD on scan. The third is a 25-year-old primie, married for 10 months, came in with a booking blood sugar of a fasting of 132, a postprandial of 283, an A1C of 8.6, clearly a overt diabetic who was diagnosed for the first time in pregnancy, viable ultrasound at 7 weeks, counseled and initiated on insulin, occasional fasting between 100 and 104, but her A1C came down to 5.8, had a normal growth scan, normal echo, actually was managing her to maintain her sugars quite well. This is how the baby was growing. And a delivery was discussed at 38 weeks. At 37 weeks, she had a CTG, which was reactive, good fluid. She was asked to come in 4 days later for induction. And when she came in for the induction, the registrar could not localize fetal heart tones and an IUFD was confirmed. Labor was induced and a 2.8 kilo female baby was delivered vaginally. The fourth scenario is a 37-year-old, BMI of 30, again, normal target, normal echo, 32 weeks, absent fetal heart tones, a breech with normal LICA, and she did have gestation diabetes at 25 weeks, but good control on medical nutrition therapy. So this was a macerated dead-born baby with the placenta weighing 600 grams, and the couple declined autopsy. So the point I'm trying to make is these are all stillbirths that have happened in women who are pregnant with hyperglycemia. But there could be an additional factor that was operational in each of these situations. So before we label the diabetes or hyperglycemia as the cause of the stillbirth, we need to be aware that there could be other factors which are at play. And the one that we are starting to see most commonly is obesity. It could be growth restriction, it could be advanced maternal age, it could be hypertension or preeclampsia, or it could be anomalies. So the first thing that we need to know that yes, when there is hyperglycemia, it is an association that could have certainly contributed to the stillbirth. But until we ensure that all other factors that could have played a role in resulting in the stillbirth have been investigated, we cannot confirm causation and say that gestational diabetes is the reason for that stillbirth. Now, what is the cause or what is the pathophysiology of stillbirths in women with gestational diabetes? Initially, there were some studies where it was even debated whether GDM really increases the risk of stillbirth, but subsequently, there's been a good amount of data that shows that definitely there is an increased risk in these pregnancies. And the most common reason is hyperglycemia and poor glucose control. Sometimes it can be unnoticed, prolonged or repeated hypoglycemia. Occasional hypoglycemia is not so much of a problem. The fetuses are able to handle it, and hypoxia and acidosis. And in 1/3 of cases, other causes were found. So when there is a combination of hyperglycemia and hypoxia, then you have a greater risk of fetal death. So as I said, fetal hypoxia, fetal acidemia, and alterations in the maternal and fetal metabolism are the reason why we have the unexplained stillbirth in all diabetic pregnancies and in GDM. And we may, even when we think we are being very watchful, we may end up with a stillbirth because we do not have the right tools to pick up this problem. Because what is happening is alterations at the level of the basement membrane of the chorionic villi, which decreases the oxygen transfer. There is decreased in diabetic pregnancies which have vasculopathy, there is decreased uterine blood flow. And in 20% of fetal deaths, there is evidence of asphyxia before or during labor. So this is, of course, more in pre-existing diabetes than in gestational diabetes. But in babies of mothers with gestational diabetes, there is a reduced capacity for oxidative metabolism. And so you can have, because there is hyperglycemia and there is hyperinsulinemia in these babies, then they are more prone for increased fetal lactic acidemia, even if they don't have hypoxia. So when there is mild fetal hypoxia, this fetal hyperglycemia combination causes a sudden shift and more severe acidosis, which can result in fetal death. And there may not be any change in the uteroplacental blood flow to be reflected in the Dopplers that we traditionally follow in situations such as IUGR, where there is a classic Doppler cascade that we can follow. In addition, there can be fetal hyperkalemia that can result in arrhythmia and fetal death. So there's also this hyperinsulinemia, which functions as a glucose sink, which may sometimes decrease the maternal insulin need, which is why many times we worry if the mother's insulin requirements suddenly reduce. But really, there isn't much in literature that I could find as evidence to support this hypothesis. So there are animal studies, especially in rats, which show that this maternal hyperglycemia resulting in fetal hyperglycemia induces an increased oxidative stress. And this causes an increase in apoptosis or programmed cell death in embryos exposed to diabetic pregnancies. And in those rats, in those animal studies, antioxidant treatments seem to diminish the damage. Now, one of the problems that is traditionally quoted or that we are conscious of is that because the hyperglycemia is tending to push the baby's growth up because of adiposity deposition, the growth restriction may be masked. But that is not true if you're actually following the growth trajectory or the growth velocity on a chart, which is why it becomes extremely important for us to plot the growth on a chart. And it's important for us to also watch out for too tight a control or calorie restriction, and to watch out for other comorbidities such as obesity or hypertension and preeclampsia. And it's important to plot the growth and watch it. And it may be important also to pay attention to some extent on fetal adiposity, which may be present in babies of mothers with GDM, even if they don't actually have macrosomia or go above the 85th or 90th centile. Now then, what are the keys to prevention? The first would be to identify this pregnancy with GDM. The second would be to offer comprehensive care to achieve and maintain euglycemia. And then we'll see what we can do with fetal surveillance. And the only resort that we have as obstetricians in many situations is to time the delivery appropriately. So making the diagnosis is extremely important, and there have been many studies which have shown that the stillbirth rates in untreated, treated, and non-diabetic groups are distinctly different, with much higher in the untreated diabetic group. And these are a couple of studies where they have shown that it can be as high as 5.4 or 5.9 in comparison to 1.8 per thousand. Now, this was an interesting paper that I came across while preparing for this talk. This is a study from UK where they have looked to see what happens to women who are known to be at risk of GDM but have not received screening, because they don't practice universal screening since their overall prevalence of gestational diabetes is low. So if you take women who are known to be at risk of GDM based on the criteria, their risk of stillbirth is modestly higher when compared to those who are not at risk. But if you took women who were at risk who did not receive the blood glucose screening, then they had a 50% higher risk of stillbirth when compared to women who did not have risk factors. And once they did receive screening, then their risks were fairly similar, because one assumes that once they were identified as gestational diabetes, they then went on to a treatment arm where they were monitored. And the risk of the late stillbirth was raised in women who had a raised fasting glucose, and twice as high as those who had a normal fasting glucose among the GDM, which emphasizes the need for us to look at the fasting levels as well, and not just the post-glucose or the postprandial sugars. So they comment in this article that the variation in practice leaves many women with borderline hyperglycemia exposed to an avoidably elevated risk of stillbirth. Now, in India, the national policy, and something that we all scream off at every meeting or every podium, is universal screening. And that we screen at first contact, and then if normal, we screen again at 24, 28 weeks, and if high risk, we look again at 32, 34, simply because our prevalence is so high. However, how we screen is not so much the issue as are we using the right criteria? And this was a study that we did as part of the WINGS protocol, and we found that barely 18 to 19% of both obstetricians and diabetologists, endocrinologists actually matched the criteria with the test that they were using, which means that many women may actually be labeled wrong because you're using the wrong set of criteria to make the diagnosis with a different test. So just to emphasize that universal screening is extremely important and probably the first most important step. The next is to have a comprehensive care plan, which means we have a good glycemic control. We want to minimize macrosomia. We also want to monitor her blood pressure, because we know that the risk of preeclampsia and placental dysfunction is higher. But even without the incidence of preeclampsia, there is something that's going on with this diabetic placentae, which can compromise at the level of the endothelium. And we want to manage maternal weight gain, and therefore it's extremely important that we tell these mothers what their optimal weight should be based on their BMI. And here again, we have an issue because our BMI cutoffs and the weight gain cutoffs for pregnancy based on the IOM recommendations are not based on the Asia Pacific standards. And here again is an opportunity for us to actually come up with the standards that are useful. Now, the other aspect where I think we need to do better is the effect of diet and physical activity before or in addition to the medication that we show, because as was shown by this analysis by the IWIP group about 4 years ago, when you actually implement good diet and physical activity, there is a reduction in the prevalence of gestational diabetes, more with physical activity than with diet alone. There is also a reduction in hypertensive disease, which is quite significant, as well as a reduction in cesarean section. So we just need to get our women to move more and have less carbs. Now, is there any data that having tighter control or more intensive control reduces stillbirth? This is a systematic review where they showed that there was an 80% non-significant reduction in the risk of stillbirth when with intensive management protocol compared with a more relaxed protocol. And when you compared optimal versus suboptimal glycemic control, while there was no statistically significant difference in the risk of stillbirth, there was a definite reduction in the perinatal mortality. Just to emphasize that really the glycemic control is important. Now, when we say glycemic control is important, we know what the targets are, but the question is how often are we monitoring these women? Because in many practices, we don't do the 6-point sugars, especially if they're on medical nutritional therapy. So they may come back with a sugar once in 10 days or 14 days with a fasting and one postprandial value, which may be something that they have done very well on the day of the test. But in the remaining intermittent period, they may have had episodes of hyperglycemia, which we have not picked up because we are not monitoring enough. Which is why, like in the third scenario that I presented earlier, you may have a woman whose sugars, as you see them, may be normal, but this baby is growing higher. Weight is going bigger, there's polyhydramnios. And we must remember that the impact of the hyperglycemia is on the fetus, and therefore, when we are trying to ensure that there's glycemic control, we need to put all these factors together, and we probably need to ensure a little bit more monitoring even when they're on medical nutrition therapy. And if we can't do the growth every 4 weeks, at least at 28 and 36 weeks, look a little bit beyond biometry for fetal adiposity, because that disproportionate fat distribution is what puts these babies at risk, not just at the time of delivery, but also for an increased risk of stillbirth. The adiposity independently can increase the risk. And as Dr. Maheshwari mentioned, that is what really puts them at risk for metabolic diseases in adolescence and later life. So it's very important that we use that to modify control. Nusrat had raised the query of fetal surveillance, and we all do increase the third trimester fetal surveillance, but unfortunately, our tests of fetal surveillance are not meant to detect metabolic compensation. They are meant to detect any placental dysfunction. And in fact, the problem with the CTG is it can only pick up an acute problem. You cannot monitor to see what is happening even in the context of a placental dysfunction, what is happening overall over a period of time. So you have a CTG and a biophysical profile. It can pick up an acute problem. It does not prevent it, which is why you may have a stillbirth within a week of a normal CTG. And in one study, 9 out of 12 acidemic fetuses of diabetic mothers actually had a normal BPP, and 6 out of 12 had a normal fetal heart rate variability within 48 hours of a stillbirth. So we really don't have a very good tool, but we do it because we feel good if we see a good CTG, and it actually brings the woman back a couple of times into the contact with a healthcare professional for us to identify other risks such as blood pressure. But clearly some babies are more at risk. So if you have an infant or a baby which is under the 10th centile, over the 95th centile, any baby that is crossing centiles, these babies obviously are at greater risk than those which are maintaining their growth. So coming to the last bit of my talk, which is the only tool that we have to prevent a stillbirth, which is to time delivery. Is there any evidence? Or do we just pick the number that we like, 37, 38, 40, or 41? The point is what we are trying to do is balance the risk of delivering this baby too early and putting it at risk of RDS and premature, that these babies are at more risk for RDS versus a baby that's going to get bigger or have a late IUFT. And this is an interesting study where they showed that obviously stillbirth rates go up with gestation irrespective of whether they are non-diabetic or diabetic, but clearly in a diabetic it goes up higher than in a non-diabetic. And they found that when you have with increasing gestational age, you can see what is the impact, and they compared the risk of stillbirth with the risk of what happens with expectant management. And they said that at 36 weeks, the risk of delivery is higher than expectant management. At 37 weeks, the risks are similar. At 38 weeks, the risk of expectant management exceeded that of delivery. And you can see that here, based upon the gestational age, what is happening to the risk of stillbirth and in these babies. Obviously, these babies are also at greater risk in labor. Doesn't mean that we can't give these mothers with gestational diabetes a vaginal birth, but we need to watch them a little bit more. We need to watch the mother, the baby, and the sugars during the process of labor, especially if she has been on medication, and especially ensuring that they don't starve and get into starvation ketosis or things like that if they are in prolonged labor. Obviously, we need to watch for progress, watch the partogram, because we need to be prepared for dystocia and use the instrumental deliveries where appropriate. The fact that the woman has gestational diabetes is not and should not become an indication for her to have a cesarean section. So I want to conclude by saying that GDM is a spectrum. Some babies are more at risk. It's important for us to identify them, the mother who has hyperglycemia, stratify her risk, try and see if we can prevent her from developing GDM in the first place. But for that, we need to ensure that she's advised on diet and physical activity when she has risk factors, and be aware and watchful and avoid iatrogenic prematurity. Ensure that we are able to get good glycemic control. And sometimes we hesitate to tell these mothers that their babies are at risk of stillbirth. We don't want to say it because we don't want to scare them, but in the higher risk mother, it's important that we have her buy in and take responsibility for that better glycemic control, which she certainly will do if we communicate to her that her baby is likely to be at risk of dying in utero. And with all of these strategies, we can probably minimize the stillbirth in GDM. I'm not entirely sure that we can avoid all of them. Thank you very much for the opportunity.
Thank you so much, Dr. Uma. A few more questions are there, and there's still some time, about 10 minutes. Doctor, I can see Dr. Torvid here. I think there's one question for you. Do you take any cutoff of abdominal circumference for offering a cesarean section in your protocol, even if the baby is AGA, appropriate for gestation age?
No, we don't use. We use estimated fetal weights. But I have a small question for the last comprehensive, very nice talk. Do you use computerized CTG or use just conventional eyeballing?
So conventional CTG, we don't have computerized CTG as yet available in India. In fact, I have explored and reached out to the companies, but they don't even have a sales guy in India. So we just use traditional, the eyeballing CTG. Yes.
Yes. We think there is a huge difference.
From what I have read and from what I have heard, I think if we are starting to see a lack of variability and decelerations, at which point we'll probably bail out. There may not be too much of a difference in the antenatal surveillance. But I really don't know. Because I've asked this question when every time truffle study comes up, because we don't have that computerized CTG and we only have the Doppler. And when you know that they used that safety net in a third of their babies, we don't know how we're going to use that in our, how do you translate that into our context?
No, we have changed all our surveys into computerized because you get the more accurate numbers which a computer can do better than eyes can do. But the Americans are not agreeing.
There's always a difference of opinion across the Atlantic, isn't it?
Dr. Bharti, I think there's a question for you. If ventricular hypertrophy is detected on fetal echo in diabetic mothers, how should we follow them? And what is the incidence?
Yeah, Dr. Tamkin, as I have already mentioned in my talk also, that the incidence of hypertrophies in a wide ranges around 25 to 75%, and it depends on whether diabetes is pre-gestational or the gestational and severity and blood sugar controls and all. But all and these hypertrophies mainly due to hyperinsulinemia, and mainly they are transient and they recover in the 3 to 4 weeks when the insulin level normalized after delivery. And sometimes in some cases the fetus is symptomatic. In such cases you need to treat the cases, and mainly the role of propranolol and supportive therapy. So in the third trimester to diagnose the echo and seeing the hypertrophic cardiomyopathies, it is not recommended in each case. The purpose is only we have to control the blood sugar, and we should try not to have a compensatory hyperinsulinemia in women. But it happens because if woman is remain diabetic, then it resolves in 3 to 4 weeks. But we have to only keep eye on all these factors.
Okay, thank you. What is tight control? I think you already answered that, Dr. Uma. What is a tight control?
I think increasingly people, you look at the numbers and look at the percentage of time that the woman is outside what is considered the normal range. Of course, it's a little bit better defined when you do continuous glucose monitoring, because then they say the time in range and time out of range. But I think it's important that the targets that we have, which is a fasting under 95 and a postprandial 1 hour under 140 and a 2 hour under 120. And also look to see what's happening to the baby, because we know that the impact of mother's glucose on the baby is not an absolute cutoff above which or below which things are normal. It's a linear association. So, which is why sometimes you may see mothers where the sugars are not that bad or looking normal, but the baby is showing evidence of impact of hyperglycemia. So I think that's the reason we need to look at both factors to keep an eye.
Thank you. There's another question from Dr. Dalia. Is there any association between GDM and IHCP together on stillbirth besides GDM and hypertension? GDM and IHCP.
Intrahepatic cholestasis of pregnancy in itself does increase the risk. I am not aware of a specific association of GDM with IHCP, but I remember reading something about it, but I'm not quite sure to answer right now. I don't know if any of the others, Muzat.
I haven't heard of such an association as such. Haven't searched that question too. Maybe Anyone else who can answer? Maybe I haven't searched that question, to tell you the truth.
I think I heard it in passing when Catherine Williamson was giving a talk at the RCOG conference, but I didn't quite register it, so I've not looked it up. But it's certainly something we can look up.
Yeah, look at and continue on the group.
There was a question about lipid profile assessment. So I think there is a fair interest in what happens with lipid profile and babies' growth, etc. But it's not something that we are doing routinely. I don't know if they are, Dr. Torvid. Do you look at lipid? Because there is an association with triglyceride excess.
Yes, but we don't screen or go for that.
Yeah.
Not in pregnancy.
There are lots of compliments, Dr. Navneet Thakkar, very practical talk. Excellent talk, Dr. Uma, excellent talk, very practical approach. People want to thank Dr. Torvid for his excellent talk and interaction. And
Dr. Tamkin, one thing I would like to request. Very good sessions and we are all learning. But Dr. Torvid, thank you very much for coming here and giving interaction. But there is one request. If you can fulfill, I have requested this to Dr. Nazat also. If I can get your one article or some for our GDM committee's newsletters to read by all audiences regarding the fetal surveillance protocols, which is recommended latest in the GDM patient. Dr. Torvid, if you can mail it us in around 10-15 days, then it would be really very useful for us.
Yeah, I think when I got this question about management, I think I was answering rather by beating about the bush. So, but because there is a huge difference between what we are doing here in my country and what we are doing, for instance, in Ethiopia, where you really are fighting a different problem. So I can easily send you, but what I listened from the discussion and the presentations here, you are really very, very experienced in this problem in your country. And you have really experts in this field. So I'm sure you will develop this kind of questions much better by your own background than by seeing what we are doing, because in the end we are still trying to find good monitoring tools, and we haven't got the best yet.
Okay. Thank you.
so, Dr. Anuj.
Thank you for giving me this opportunity. And really, as much as I can praise Dr. Umaram, that is less. It has been a wonderful talk, not only informative and good for the gynecologists and obstetrician, but also for the physicians also. And I really liked it when you have taken the issues of the glycemic variability, when you have taken the issues of the postprandial hyperglycemia. Very less people think about these things, which are very much important as far as the fetal growth is concerned, as far as the female safety is concerned. We must focus on these two things. When I heard the question, what is the tight control? So I would like to answer this question in the way that tight control is that when you are keeping the glycemic variability at its least. And now we are having these kinds of the devices like CGM, like Libre Pro and Libre. You can measure and you can check the glycemic variability very well, and they are not really costly. So you can really use them and you can look for that, and you can ensure the safety of the baby, as well as you can also avoid the mother to becoming diabetic in the near future. As far as we have the differentiation of the diabetic mother and GDM mother, these are the two very different categories. As Bharti has very rightly said, that hypertrophic cardiomyopathy as well as other cardiovascular diseases and malformations, they are more commonly seen in the diabetic mother, whether it is type 2 or type 1. Whenever there is a diabetic mother, very rarely we see that that mother takes their glycemic control very good then and enter into the pregnancy. Mostly enter into the pregnancy without checking whether they are glycemic control having or not. And most of them remain on the oral medication. And once they enter into the pregnancy, once they know about their pregnancy, then they switch over to the insulin, then their clinician or their obstetrician switch them over to the clinic insulin. And that is also becomes not so much good for the fetal growth, because when you are switching them, that is around 4 to 8 weeks of the time. That is the time when organogenesis is already going, and you are switching the patients on the oral to the insulin. Again, you are making him or her, again you are making her on the uncontrolled glycemia by switching during that switching process, and that makes it open for the glycemic variability very high. That makes it open for the uncontrolled hyperglycemia, and that invites unwanted complications, may it be abortion, may it be fetal malformations. So fetal malformation we do not see in India, because in India we see more of the GDM pregnancies. We get lesser pregnancies which are having the diabetic mother as compared to the GDM. The one important reason may be the gestational diabetes or pregnancy may be one of the precipitating time when the diabetes is reflecting. Because one of the diabetes mentor to Professor Shashia always say that gestational diabetes is a predictor of the diabetes. It is a pre-information of the diabetes, forthcoming diabetes. It is alarming you, alerting you for the forthcoming of the diabetes, because once your pancreas is not so much capable enough to meet the challenges posed by the pregnancy for the insulin resistance, then only you are going to have the gestational diabetes. And this is a signal that you are a person who may develop diabetes whenever your pancreas is being over challenged. And one question what I could see that how can we really avoid the gestational diabetes? How can we really avoid the stillbirth and gestational diabetes? This can only be avoided if you can keep the insulin resistance at the peak. And insulin resistance can only be reduced by putting up yourself on more and more exercise. You keep remember always, when you are getting hyperglycemia today, the foundation of that hyperglycemia is kept about 15 to 20 years before, with insulin resistance, which has started rising. It initiates the process of atherosclerosis. It initiates the process of other difficulties which may arise because of the insulin resistance by the endothelial dysfunction. Endothelial dysfunction becomes the initiating thing. So if we keep all these things in our mind, if we promote that every mother should be having good amount of the exercise, good amount of the diet management before going into the pregnancy, whether she is diabetic or non-diabetic, because if she is diabetic, he has to do it anyway, and she should be shifted over to the insulin before entering into the pregnancy. But if she is GDM, she may not be knowing whether she will be GDM detected in the pregnancy entering. But if the family history is there, the chances of getting detected gestational diabetes is more. In such women, they should keep control their weight, they should start doing the exercise, as well as they should keep their diet in the way so that it may not be causing more of the glycemic variability. I think that what I could understand and what I could really inspired by Dr. Umaram's talks when she said all these things, and these things came to my mind to share with all of you. And of course, the rest of the speakers were definitely very good.
Thank you, Dr. And I think
I now request Dr. Dalia to please give a formal vote of thanks. Please unmute yourself. Yeah.
Thank you, Mom. It's really my privilege to propose a vote of thanks and acknowledge the contribution of those who really work hard to make this event happen. And I think a successful event happen. And on behalf of GDM Committee, I really extend hearty thanks to our international expert, Dr. Torvid, and our chief guest, Dr. Anuj, who spared their precious time from their busiest schedule to grace the occasion and for being with us throughout. We are really thankful to you, sir. Today we have an opportunity to hear from such learned speakers, and what an academic feast it was. A thoroughly mesmerizing talks to hear from all of you, and a good food of thought from the talk of Dr. Torvid, from Dr. Bharti, and so well explained talk from Dr. Oma. We all really are enlightened from your talks and really enjoyed it. And an event like this could not happen overnight. The wheels start rolling weeks ago, and we have been fortunate enough to be backed from very proactive and dedicated dignitaries of the Stillbirth Society, the president, the vice president, and the secretary and joint secretary of the society, who are so well versed there with their jobs, their ideas, and elegance of explanation of everything need deep sense of appreciation from us. And a very special thanks to our respected chair, Dr. Bharti Maheshwari, for her untiring efforts and for being the catalyst that stimulated all to do their best. I also extend thanks to all committee members for being with us and for their cooperation for the newsletter. We also want to thank people who supported behind the scene, that is the technical support team, and lastly, but of course not least, our audience who so patiently heard the talks and are instrumental in making this event successful. Thank you.
Thank you so much. Thank you so much for each one of you. Bye-bye. I think we need to speak.
Okay, bye-bye. Good night, everybody.